Good evening. Thanks for coming. We are incredibly grateful that you took time of all the things that you could do for the Saturday Night at Academy, and you came out to see our presentation. My name is Michael Singer, and we're going to talk to you today about DME in the real world, past, present, and future. Basically, without further ado, I'm going to have Seenu come up and talk about the current therapy to give you both a historical and present idea of the current landscape going on. Without Seenu.
Thank you so much, Michael, for the kind introduction. Michael really didn't introduce himself, and we all have to thank Michael for being the most wonderful course director and helping put together the grant, and also thanks to Allergan for sponsoring this CME program, which is very much appreciated. So are we taking questions along the way, or what are we doing? Yeah. Okay, wonderful. So just to, keep your questions. I think there's some way to text them to Michael. Do they know how to text them? Yeah, there's a way to text questions, so just raise your hand and our moderator will help with that. So what I want to do today is get a good baseline understanding of diabetic macular edema, the current therapy, look at comparative therapies and where we're going in the future to set the stage for the future lectures. Laser photocoagulation is a very important tool to have in our toolbox to treat diabetic macular edema. As you know, it's the application of high energy light to the retina. It's absorbed by the retinal tissue, it generates heat, and this clotting, this burning can coagulate vessels. It actually destroys tissue and can decrease the local metabolic load, and it also destroys the tissue, the cells that produce angiogenic factors, but the goal being to preserve the central retina. Now, one of the finest studies done in our field is the ETDRS study, the Early Treatment of Diabetic Retinopathy study. And what this study showed is that if you pick patients who have clinically significant diabetic macular edema, there's a decreased risk of moderate vision loss with the use of laser. At year 3, you drop the rate of moderate vision loss from 23 to 12%. So focal laser does work, and you may need repeat focal laser treatment. This is a patient of mine from my own fellowship. And you can see with a very careful patient selection, a patient has clinically significant diabetic macular edema. With one single laser treatment, look at the resolution of diabetic macular edema. It's a finite treatment. You don't need repetitive treatments in some patients with focal disease, so it makes a lot of sense to at least think about this treatment. In this day and age, we typically combine it with intravitreal injections. But there are shortcomings of laser photocoagulation. It's destructive, as I mentioned. It's a slit lamp delivery. Very awkward positioning for the patient and for the provider. Manual focus. There's no view of the fluorescein angiogram. And so this always has been a problem. So the accuracy and precision is based upon the physician and the patient. Now, the technology, thankfully, has improved tremendously from the 1940s to the current day. You can see in the past, as recently, I think as the 40s, natural light was used. Sunlight was used to photocoagulate the retina. And you can imagine, I'm from Chicago. I don't think we could laser the retina for 4 months out of the year. So this is very problematic to use sunlight to laser the retina. When I was in Germany, I actually helped develop this technology that I'm going to talk about next, the Novelas laser. But I was in a retina specialist office in Germany, and I saw a pristine xenon arc laser that you see in the corner, an incredible advance in the way retinal photocoagulation was performed. And now targeted laser, the Novelas system, navigated laser, has an incredible technology that is not a slit lamp delivery. It's an integrated platform where a patient can be imaged. You can actually plan the treatment on the device, and then you can conduct the treatment very promptly and with excellent documentation. So you can actually superimpose the fluorescein angiogram on the treatment plan on the live tracked fundus image. So in summary, laser photocoagulation has been the gold standard for treating diabetic macular edema for over 25 years, and now it's frequently used in conjunction with intravitreal pharmacologics. But if you can identify that patient with very discrete focal leaking microaneurysms that are away from the central fovea, it's certainly a treatment that you can think about. Now, anti-VEGF therapy has revolutionized the way we manage diabetic macular edema. Why anti-VEGF? Well, there's good evidence for it that in diabetic patients, VEGF levels are through the roof. If you look at DME patients versus control patients, and you look at vitreous levels of VEGF, I mean, it's multiple fold higher in the diabetic patient. And this is because of the ischemia, all sorts of factors that are released in the eye. So it makes sense to use an anti-VEGF agent. There are three therapies that we use for diabetic macular edema. The first one is Avastin. It's an off-label treatment. It's a full-length antibody. Then we have Lucentis, which is a much smaller molecule, about 48,000 Daltons, and it's approved for diabetic macular edema through the RISE and RISE phase 3 FDA registration trials. And then we have aflibercept or Eylea, and this is not only anti-VEGF, but anti-PLGF or placental growth factor, and the VIVID and VISTA FDA registration trials allowed for its approval in diabetic macular edema. Now, in the Ranibizumab phase 3 trials, there were three groups, sham injection versus 0.3 and 0.5 milligram of Ranibizumab. 2 years of monthly treatment, and then these patients who were transitioned, the sham group went to the 0.5 milligram dose of Ranibizumab, the 0.3 milligram group stayed the same, and the 0.5 milligram group stayed with 0.5 milligrams out to 36 months, and then there was an extension study. In orange, you can see the patients who are treated with Ranibizumab with very high dosing frequency, monthly injections of Ranibizumab. Look at the very robust and prominent improvement in vision, especially in year 1, 9.1 letters. And then there's about a 2-letter improvement in year 2. But in year 3, with 12 monthly injections, we see under a letter of vision improvement. So there's sort of a plateau in year 3. But if you look at the sham group, for the first 2 years, these patients were not treated. And then after you intervene with 0.5 milligrams of Ranibizumab, you do see about a 2-letter increase. This delay in treatment indicates that the photoreceptors are dying with the chronic edema. So even though you can dry the retina after 2 years, the vision gains are limited. In yellow, you can see the very rapid and a very robust drying effect of the Ranibizumab therapy compared to the less prominent OCT drying effect of the sham group converted to Ranibizumab therapy. The aflibercept phase 3 registration trial had 3 groups, aflibercept 2 milligrams every 4 weeks, aflibercept 2 milligrams every other month, every 8 weeks, and laser photocoagulation, and the primary endpoint was best-corrected vision at 52 weeks, and the study continued for 3 years. Something very interesting in the FDA registration trial for DME in the VIVID and VISTA study is that whether you use aflibercept every other month or monthly, the outcomes are the same at the end of 100 weeks. This is a very important outcome because we just dropped the treatment burden with Lucentis down to every other month dosing with aflibercept. So this truly was an advance. It's not that the patients see better or the vision is much better. The fact that you can do less injections and achieve the same outcome was a very, very important advance. OCT data was very robust. Whether you use every other month Eylea or monthly aflibercept, you can see that the OCT is roughly the same in the 2 different groups. One big advantage of the anti-VEGF therapies is that not only does it treat diabetic macular edema, but it can also treat diabetic retinopathy. A number of patients, nearly 40% of patients, can see a 2-step reduction in diabetic retinopathy scores. So this is a really nice advantage of the anti-VEGF agents, and there's some evidence as well that steroids can also improve diabetic retinopathy scores, and I'm not sure if Dr. Wyckoff will be presenting this later, but it's a very interesting data that there's something beneficial of both anti-VEGFs and steroids. Now, when you look at an overview of clinical trials in diabetic macular edema, on the x-axis, you see the number of injections, and the y-axis, you see the mean vision gain. Our goal is to be here. We want to have a high vision gain with a low number of injections. With Ranibizumab, you can have excellent vision gain, but the treatment burden is very high, as evidenced by the RISE and RIDE study, but the vision gain is quite impressive, but you need 12 injections a year. With the every other month aflibercept group, you can see that you cut the treatment burden significantly, but maintaining the same visual outcomes. So this is the benefit of aflibercept therapy. Now, what happens if you try to decrease the number of injections with Ranibizumab? Then you can see that the mean vision change decreases. So this is the problem. The treatment burden is very high with Ranibizumab. So, in summary, VEGF clearly is a key player in the development of diabetic macular edema. It provides significant improvements in visual acuity, it improves retinal anatomy, and importantly, it decreases diabetic retinopathy scores. Now, the companies have done a great job getting monotherapies approved to help us treat diabetic macular edema, but the problem is it's very dangerous to compare cross-trial, molecules cross-trials because the inclusion-exclusions are different, the patient populations may be different. So the best evidence is a head-to-head comparison of these molecules. So I'm going to present the DRCR network protocol T data, 2-year data. And this is the first comparative trial of the available anti-VEGFs to treat diabetic retinopathy and diabetic macular edema. It's funded by the National Eye Institute, and it compares aflibercept, bevacizumab, and ranibizumab head-to-head. This study was of such significance that the data was published in the New England Journal of Medicine. 3 different groups, as I mentioned, 1-to-1 randomization, 2 milligrams of aflibercept, 1.25 milligrams of bevacizumab, and 0.3 milligrams of ranibizumab. Now, when we look at the overall data for 2 years, what we see in year 1 is that aflibercept has a very slight advantage, needing 1 less injection compared to the other 2 arms, bevacizumab and ranibizumab. In year 2, there really is no statistically significant difference in terms of the number of injections required in the study. But there's one big curveball, a confounding variable. In this study, focal laser was allowed in case patients had persistent diabetic macular edema. You can see in the aflibercept group, only 41% of patients required adjunct treatment with laser, 64% of patients with bevacizumab, and 52% of patients with ranibizumab. So the question is, from between year 1 to year 2, if the efficacy was impacted by this increased number of focal laser treatments required in the non-aflibercept groups. So let's take a look at the time course of vision change in the 3 groups. Here we have year 1 data, and here we have year 2 data, orange being aflibercept, yellow being ranibizumab, blue being bevacizumab. At year 1, aflibercept clearly was the winner over both ranibizumab and bevacizumab in terms of vision gain. But from going from week 52 to week 104, you can see that the aflibercept group loses just a little vision. The ranibizumab group increases just a little bit. So this difference is no longer statistically significant. We wonder if the additional focal laser treatment, and focal laser does work in the treatment of this disease, if that caused this increase in the vision in the ranibizumab group. And bevacizumab numerically is the lowest in terms of vision gains out of the 3 different groups. Another important thing to point out is when looking at baseline vision, here being good patients with good vision, 20/40 or better vision, versus worse than 20/40, you can see that aflibercept has an advantage over the other molecules in terms of improving vision. So the worse vision, there seems to be some advantage to aflibercept therapy. It was more prominent probably in the year 1 data. And if you look at OCT thickness in orange, numerically, the aflibercept group does the best, but it's not statistically significantly different than the ranibizumab group. However, if you compare bevacizumab, it is worse than the other 2 groups in terms of its drying effect of the retina. So in summary, all 3 anti-VEGF agents are effective treatments for diabetic macular edema and can really help in this disease. The vision gains were seen with all 3 drugs at year 2, but differences did exist between the need for focal laser, and this is a confounding variable in this study. At worst levels of initial visual acuity, aflibercept does seem to have an edge over the other 2 molecules. So I would encourage you to text your questions to Dr. Singer if there are any along the way, and then whenever the time is appropriate, we'll take those questions. So now we're going to switch gears and talk about corticosteroids. Corticosteroids are anti-inflammatory, but they also inhibit the VEGF gene. There are 2 major steroids that we use. Both are sustained delivery devices. The first one is Ozurdex. It's 100% biodegradable. And the other one is non-erodible, and that's the Iluvien fluocinolone implant. There's some evidence that in more chronic DME, inflammation is more important compared to acute DME. You can see these inflammatory factors start to escalate in the eye, as time increases with DME. So it makes sense to incorporate steroids in the treatment paradigm. You can see that corticosteroids inhibit a whole host of inflammatory factors as well as VEGF, versus the anti-VEGFs are a very big sledgehammer against one molecule, and that's VEGF. The Protocol I study gave us very important insights that corticosteroids can have very good efficacy comparable to that seen with anti-VEGF agents. So when looking at pseudophakic patients, you can see that the triamcinolone group did as well as the ranibizumab groups. Of course, in phakic eyes, triamcinolone causes cataracts, and so you did not see this effect. Really, the pseudophakic patients was where the benefits were seen. But we have another FDA-approved drug called Ozurdex, the dexamethasone implant, and this is a sustained-release biodegradable steroid implant. It's 0.7 milligrams of dexamethasone. And over time, it degrades into lactic acid, glycolic acid, it's essentially carbon dioxide and water. And this is what the implant looks like. It's a small pellet that's dropped in the eye and completely dissolves with time. In the MEAD FDA registration trial, we'll focus on two arms, the dexamethasone 700 microgram group and the sham group. It was a 3-year study, and treatment was allowed every 6 months. You can see that in phakic patients, the data was not as robust as the pseudophakic patients where there clearly was an advantage to treatment. But if you look at 3-line vision gainers, clearly the dexamethasone group did well with a 22% rate of 3-line vision gainers. Among patients who are phakic at baseline, 61% of subjects in the dexamethasone implant group needed cataract surgery versus 8% in the sham group. And the incidence of cataract really increased with time, really after year 1. But the vision improvements were prominent, especially after cataract surgery. So you can see in this group, light green is the Ozurdex group and white is the sham group. You can see that right around right before the cataract adverse event was reported, the vision dropped. But soon after cataract surgery, notice how the Ozurdex arms did even better than the sham group. So there's something protective of having a steroid in the back of the eye in the setting of cataract surgery. And ultimately, these patients do better because you're protecting the macula. And I'm convinced that the fluidics of cataract surgery wash anti-VEGF out of the eye, but this pellet stays in the back of the eye throughout the whole process of cataract surgery. So there's something, it seems there's something protective of having an Ozurdex pellet in the back of the eye. Ultimately, those patients who develop cataract, 6.6 letter vision gain after cataract surgery, but the sham group is only 2 letter vision gain. IOP rise does occur, but it's very manageable. The vast majority of patients need a topical drop to manage it, and that's about it. And only one single patient in this trial needed incisional surgery to manage the pressure. If a patient does have an IOP increase while receiving the dexamethasone implant, in light green, you can see that these patients only needed one active ingredient most of the time. And as I indicated, only one single patient in this 3-year study needed incisional surgery to manage pressure. The other implant that is FDA approved for diabetic macular edema is called the Iluvien fluocinolone acetonide implant. It's non-erodible, and it has a very unique FDA label. It's approved for the treatment of diabetic macular edema in patients who have been previously treated with a course of corticosteroids and did not have a clinically significant rise in IOP. And this is what the implant looks like in the back of the eye, and this is the size. The yellow shell stays in the eye forever, but the fluocinolone dissolves over the course of 3 years. In this study, 0.2, 0.5 micrograms of fluocinolone acetonide were evaluated compared to sham. A primary endpoint at 6 months, and the study continued for 3 years. And you can see that it's very effective in terms of 3-line vision gainers. At the end of 3 years, 28% of patients with 3-line vision gainers. And likewise, the OCT has a very robust drying effect over time. Now, the FAME study was problematic because patients had a high rate of IOP elevation. But keep in mind, the FAME study had all comers, patients who did and did not receive a previous course of corticosteroids. But incisional surgery occurred with a rate of about 5% in this study. But if you look at the cohort of patients that had a previous course of corticosteroids and didn't have a problem with IOP, and then received the fluocinolone acetonide implant, there was 72 patients like this in the clinical trial. 0 patients needed incisional surgery to manage glaucoma. So that's why the FDA gave them this unique label, stating that they had to have a previous course of corticosteroid before using Iluvien, and there was no clinically significant rise in intraocular pressure. So clearly, based on the clinical trial data, the dexamethasone implant is the safest, only 0.3% rate of glaucoma surgery. And you know, all these drugs have a rate of cataract, but the Ozurdex implant is the lowest. Triamcinolone acetonide has very high rates of glaucoma surgery and cataract, as does Iluvien per the FAME study. So in summary, significant improvements in vision in patients implanted with corticosteroids compared to sham group with relatively few injections is the main benefit of the steroid implants. Increases in IOP do occur, but they're very manageable, and longer exposure to corticosteroid implants was associated with the formation of cataracts, but this is very much a treatable condition. So I want to wrap up my section with one case. This gentleman is an African-American gentleman, 55 years old. He is a painter in my hospital. He's an interesting character. He is scared to death of injections. There was one time I wanted to do an injection. We set up the tray and opened up the, at that time he was getting an anti-VEGF. Before I could walk in the room to do the injection, he ran away. And we were paging him in the hospital. He wouldn't come back. He's that scared of injections. And, but now he's doing really well. Very sick gentleman, as are most of these patients. He's had vitrectomy in both eyes. He's had PRP laser in both eyes. He's had Avastin, Lucentis, you name it, he's had it. And he's phakic, this gentleman. No glaucoma, but severe non-compliance with his visits. So I tried Lucentis in both eyes. He has a mountain of macular edema, 20/70, 2100 vision. But look at this, very diffuse, just terrible diabetic macular edema in each eye. I don't even know how he paints anything in our hospital. And so he comes back, and he still has a mountain of macular edema in both eyes. The Lucentis did not do much, but I decided to try it again. It's not fair to damn a therapy with just one injection. And we bring him back, and still a very modest response. Some resolution of the DME in the right eye, but not much in the left eye. The vision is stuck at 20/60, 20/80 range. So I want you to look at the en-face OCT, and at this time we're frustrated, really not accomplishing much after 3 injections. There's something called the early analysis, which says, you know, after 3 injections of ranibizumab, we should be able to tell how well the patient is doing. Okay, it's really predictive of how they'll do at 1, 2, and 3 years. And you know what you see here is that this patient is not responding well to ranibizumab. So we switch therapies and we treat him with Ozurdex. And so he received an Ozurdex pellet in each eye. He's 20/50, 20/80. Look at the en-face OCT, and you can see that with one treatment, the DME is gone. All right? Does it make sense to switch therapy in these cases? Absolutely, and this is supported by the early analysis. We could do another 30 anti-VEGF injections, and we're going to have this modest response at best. So in my practice, we really try to think about whether we should switch treatment or even add on an Ozurdex and then do anti-VEGF on top of that to really get these guys dry quickly. And we're going to talk about Protocol U data, I'm sure, and it'll give us a lot of insights that if you delay treatment, you have suboptimal responders with anti-VEGF, even if you dry the OCT, the vision's not going to improve. So you have to identify these patients early, not after you do 32 Avastin injections. After 3, 4 injections, decide, is this guy responding or not? If he's not responding, then do something else. And that's what, in my opinion, Protocol U teaches us, the early analysis data teaches us, and we should really be more thoughtful and think about this before we keep doing the same thing over and over and over again. So with that, when is a good time to take questions, Michael?